We are very excited to be having Igor Gorlach here talk a little bit about the RFI from CMS on the digital health ecosystem. Igor guides companies through regulatory healthcare, privacy, cybersecurity, and consumer protection issues with a particular expertise in the digital health space and projects involving innovative or consumer-facing technology. He is a partner at King and Spalding, and I will turn it over to you. Thank you so much.
Thank you, Lydia. Appreciate it. Thanks everybody for joining. I think the topic we have at hand is a great, fascinating topic. And Lydia, I just sent the request to share my screen so I can share the slides.
You should be good now.
Thank you. All right. All right. Hopefully that's visible. Is it visible in full screen?
Yep.
Perfect. Great. All right. So thanks for joining. We'll be talking about the HHS/CMS ONC RFI request for information on the health technology ecosystem. This is the third RFI already that has come out from this administration. Those of you that have been following know that two of the previous ones, there was one on the deregulation of certain CMS regulations, where there was a request for comments about how CMS can deregulate some of the stuff that it has done historically. And there was another one about how to put it was called Unleashing Innovation. It's how to put the patient in the center of what CMS does. And so this third RFI continues this sort of practice of an open-ended publication that's available for comments and that allows for input from stakeholders. But again, it's open-ended. There's not a lot into it in terms of indication of what's actually going to happen. But it still is a great opportunity for providers and other stakeholders to submit what they believe are good ideas. So here's what I'm hoping to cover today. A little bit of a background about this RFI, the best practices for comments. I know CTEL is submitting a comment jointly, but I'll discuss sort of the considerations around when submitting comments to CMS in particular. The general themes in the RFI, the RFI, if you look at it, is just essentially a bullet point list of questions. And so it's not easy to digest. And so I'll try to outline some of the themes that we're seeing throughout that maybe, we'll be able to read the tea leaves to see what's on CMS's mind with this. And then we'll go into a more detailed review of what the questions are within the RFI and what are some considerations or opportunities that these questions raise. This slide deck does not have any pictures, so all the entertainment is going to be provided through words and gesticulation. So hopefully that's good enough. All right, so RFI background. It was published on May 16th, comments due on June 16th. So 1 month, not a whole lot of time, but should be sufficient. And it's important to see the agencies that are behind it and then the individuals that are behind it. And so there's two main agencies. One is CMS, as you know, administers Medicare, Medicaid, also oversees the activities of CMMI with some innovative projects. The second agency involved is ONC, what historically has been deemed or called ONC and now goes by a double name of Assistant Secretary for Technology Policy slash Office of the National Coordinator for Health IT. And so the importance of the agencies is that it gives you the jurisdiction idea of what's possible and what is not possible. I'll address that in a little bit more detail later. And then there was already a Q&A held by CMS. And in that Q&A, we saw the 4 individuals who are listed in this slide participated. And it gives you a sort of an idea of what the leading team is and what their ideas are likely to be. And so as you can see, Stephanie Carlton, she's formerly McKinsey. She worked in the Senate on the Republican side. She's the main point person on the CMS aspect of this RFI. Amy Gleason is it looks like he co-leads these projects with Stephanie. And she's formerly from the US Digital Service. She was involved in Main Street Health, which is a value-based care organization. And she's actually not under CMS, but she's a strategic advisor to HHS, but she's also the acting administrator for Doge. And then two additional individuals who are involved, one of whom has background in Palantir or has worked with Palantir for many years, I think about a decade, and another person who comes from the US Digital Service. So you see a significant focus on data with respect to the individuals involved. If you look at their background and sort of what they published, so Amy Gleason, for example, she has a TED talk about how her daughter was trying to get care, and she was getting care from 10 different healthcare providers, and had those healthcare providers communicated among themselves, they would have figured out that it's a rare condition for her daughter that her daughter was suffering from, but they could not because there was not, one single platform to see all that health information. And so it just gives you an idea of sort of Amy Gleason's ideal or goal of putting all the data in one platform, have it accessible to the patients and providers. All right, what does this RFI stand on in terms of legal authorities? So the most significant legal authority for this RFI is from the 21st Century Cures Act, 2016. I hope most of you are familiar with it. Essentially, it addressed some of the shortcomings in digital health and data transmission among healthcare providers and healthcare and tech vendors. And so, among other things, it authorized CMS and ONC and also NIST to implement policies to enhance the amount of health data available through digital channels and give patients secure electronic access to their personal health information. So it's a relatively broad mandate to implement policies that help with interoperability and access to data. Since that law, there have been other laws and developments that have sort of advanced policies to continue use of data, particularly with respect to Medicare beneficiaries. So there was an executive order that directed agencies to implement policies to enhance patient access to healthcare data. There was the CMS interoperability rule in 2020 that established standards for payers to advance interoperability and data exchange, and also required payers to implement FHIR-based APIs to allow patients to access PHI. In 2020, ONC published the information blocking rule. You may recall it's implemented a provision of the 21st Century Cures Act that prohibited any person from interfering with the transmission or use of data, from making the data accessible to individuals, including patients specifically. There's also certain exceptions to the information blocking rule at this point. And then there was also the CMS interoperability and prioritization rule in 2024, which required payers to maintain a provider access API to make claim information available to providers. So that's sort of what this RFI stands on, and that gives you the legal context. It's also important to discuss the purpose of this RFI. The reason that the purpose is important is because it advises you on the scope. And so as I'll talk a little bit more later, yes, we have questions, and yes, they're enumerated questions on various aspects of digital health, and they're organized by stakeholders. But when you look at the purpose of the RFI, it gives you a better idea of what the scope really is. And so if you want to go outside the scope of the specific questions that are being asked, you are justified in doing so if you just point back to the whole purpose of the RFI and say, well, you didn't ask specifically about artificial intelligence in this context, but it would advance the purpose that you stated in the RFI itself. And so here you can see that the stated purpose is large-scale adoption of health management and care navigation applications, reducing barriers to data access and exchange, promoting better health outcomes, patient-centric learning health system. And then it looks like the agencies are also seeking input for possible consideration in future rulemaking on policies to ease health data exchange and promote innovation in consumer digital health products. So all of that is great to keep in mind if we're submitting comments that may not fit squarely within within every single question that is posed in the RFI. So what should we consider when we are submitting comments? There's actually several considerations that we have learned from submitting comments to CMS for many years. I've been doing this for about 15 years, submitting comments to CMS and other agencies, but more so to CMS than any other, because CMS has a whole annual cycle for the physician fee schedule. You have the inpatient services, outpatient services rule, the Medicare Advantage rule. So CMS provides a lot of opportunities for stakeholders to comment, and over the years we have seen some practices work better than others. And I'm going to address each one of these aspects and provide a little bit more, I guess, lessons learned from each one of these. So the first one is pros and cons of submitting any comment at all. You're as a company, you can do one of two things: you can comment or you can not comment. If you do not comment, the benefit of that is you don't have to spend resources on it. You don't have to put your name out there attached to any particular policy or position. And you can just stay in the sidelines, which works well for probably the majority of the industry. If you do submit a comment, you get an opportunity to voice your opinion. It can be anonymized. It does not have to necessarily name your company. You do have an extra argument in case you ever are trying to challenge a policy. So historically, CMS policies have been challenged in courts, like the 2 midnight rule policy, the policy on 340B drugs. There are several policies that have been challenged in court. And one of the arguments when policies are challenged are, we submitted this comment in response to a proposed rule. You did not consider our position adequately. And so, we're suing you because it was not reasonable CMS, what you have ended up with. The policy that you, CMS, have ended up with was not reasonable. And so that gives you an important legal hook if you do submit a comment. So that's one. Second one is anonymity. I touched on this already. In some cases, it makes sense to go out and put your name forward, particularly if you're proposing a specific solution. If you're or if you're an entity that is particularly innovative or significant in the industry, or just popular among patients or other individuals in the industry, that makes sense. In other cases, you may be just risk adverse. You don't want to get too much into the political spotlight, and so you prefer to proceed through either a trade organization like CTEL, or through a law firm. It is common for law firms to submit a comment and say, we are submitting this comment on behalf of a telehealth company that has this many patients and is a leader in this kind of treatment. That could be fine as well. It can take away a little bit from the effectiveness, but not much. At the end of the day, the message is more important, and the fact how we characterize the business that submits the message should be enough without necessarily naming the business. And so if you say we have helped 1 million patients, that's still going to be valid regardless of whether we name the actual business. Another consideration is the scope of the comment. And so, like I said earlier, just because we have enumerated questions and each question is specific, does not mean that we have to stay within the scope of these questions. In fact, some of the most effective comments historically have been sort of on the outskirts of what CMS was actually asking, and that is because CMS does not have a full view of the industry the way that stakeholders do. And so a lot of times they appreciate the fact that a comment can go outside the boundaries that CMS drew themselves. And it puts issues on the map for CMS. So it can be helpful. And as we go through this deck, I'll identify several opportunities that are not squarely within the scope of the questions asked, but are still worth raising and considering. Another consideration is how much detail to provide in the comment. So if you look, for example, at the comments that have already been submitted to this particular RFI, there are several that are, one sentence, and there are a few that are 15-page long. The detail itself is important to the extent that it is relevant. And so CMS does not like it. And one of the things that I've done when I was at the FDA briefly is review comments that are submitted. And so it's not useful to have detail that is not on point. And so the most effective detail is when you prescribe something, when you tell the agency, CMS, here's what you should do, and here's why. So not just broad, this kind of thing would be good. We should have some interoperability. We should support, access to data. We should utilize new technology. It should be, here's the policy you should adopt. Not in the regulatory, here's your sections, regulatory sections, but here's your policy that should be in place. An increase in reimbursement for these services, or just reimburse these kinds of services, or require certain providers to do XYZ to get full reimbursement, something like that. And here's why: how that would support public policy, how that would advance the interests of the industry and patients as a whole. So that is the format that is the most effective. It also requires a lot of thought, because you're basically thinking on behalf of CMS as opposed to throwing half-baked ideas or just your opinion at CMS and then letting CMS figure out what to do with that. And so if you have done that kind of thinking at the trade organization level or at the company level for your own company, and you present it to CMS, that is very helpful, because you're doing their work for them. And they are more likely to take elements of that or take it wholesale and say, yeah, that's a good idea. I would want to, have either a pilot or actually implement something like that. So that's on the detail piece. And also that sort of covers the tone piece. So the tone generally should be the same as CMS's tone or CMS's view, which is, we want to help patients, we want to help industry. We all realize that CMS is working with a limited budget in terms of just both reimbursement and their own regulatory resources. And here's what would be the right thing for CMS to do for the public good. Another consideration is self-promotion, whether you should discuss the product that you offer, that your company offers. And the answer is yes, if it fits within what I just said about the comment itself, the detail of the comment. And so if you have a solution that you think is right for the industry, and at the heart of that solution are the services that are provided by your company, then absolutely, features, links to YouTube videos showing how the solution works, all of that is helpful. So there you go. That's the lessons learned. Hopefully helpful for this RFI and for all future submissions or considerations for submissions as well. And here in particular, so I mentioned YouTube videos. Here in particular, in this RFI, we see something that's sort of open-minded and we haven't seen in many RFIs before, and that is a request to send examples, workflow examples, or even videos highlighting various solutions. So CMS is open, I should say CMS and ONC, the agencies here are open to little demos of products. And one thing I also wanted to note is that I have, Thinking and Spalding, we have a bunch of templates for various comments. So if you have a particular comment that you're considering and a template would be helpful, feel free to reach out to me by email, and I'll send you a template depending on sort of what angle you want to approach with. And so you can use that template to just circulate it within your company and put together a comment and send. Or alternatively, obviously happy to send anything on your behalf if you prefer to remain anonymous. So that's the preview. And then moving on to the content of the RFI itself, there's a few themes that we're seeing throughout that I think are indicative of what CMS is considering for various solutions or pilots. So here they are. One is the use of FHIR in more expanded ways, including bulk transfers, bulk FHIR transfers, particularly to support a quality data transfer from providers EHR to CMS. And another use case that appeared a couple of times is creating a provider directory using FHIR with certain particular endpoints. So these are all good suggestions that we may see in future rulemaking. Another theme that we've seen throughout is the use of digital identity credentials. Those include Clear, ID.me, and login.gov. So those are, for those of you who are not familiar, those are sort of universal identity verification tools that then allow, once you confirm your identity through those tools, it allows the pooling of various information from different sources. And so CMS's view, I think, on this with respect to these tools is they would like to replace the current password system with just the digital identity credential that'll make it easier to access information without having to compile and log into a variety of portals many times to make sure that a patient gets their information from different sources. Another theme that we're seeing is the use of digital health for care coordination and navigation. That one is relatively self-explanatory. We'll discuss it in a little bit more detail as we go along. Another theme is the patient's ability to access their own data. And I should probably add not just the patients, but also their family members, just the ability to get their own health information. And, in countries that have more hierarchical structure to the healthcare systems, that is something that's available and accessible, and it's very convenient. And the same goes to, for example, if you go to the VA, you have the ability as a VA patient to see pretty much all of your data because you're staying within one ecosystem, and it's a lot easier to compile. And I think what CMS is trying to do is the same thing, but even if you're not a VA patient. Another theme that we see throughout is expanding information blocking, and probably more enforcement of information blocking prohibition. There are certain practices throughout the industry that looks like CMS views as potentially blocking, information blocking, that can be addressed through better enforcement of information blocking. And then the last theme is the use and adoption of digital health in value-based care entities. And there's a whole section on value-based care. And I see that there was a chat thing that showed up. Let me see. Sorry, just checking as we go. Okay. It does not appear to be related. Okay, moving on. There's also a few topics or themes that are not really addressed at any sort of length. One of which is artificial intelligence. I was surprised, when you see an RFI on digital health, the ecosystem of health tech, if you go to any industry conference, you can't go 2 minutes without hearing somebody talk about AI here, AI there. And we're seeing that everywhere, right? We're seeing the use of AI and obviously claim submission. We're seeing AI in helping with care coordination, guiding patients, call intake, organizing your data. AI is everywhere right now. And so it's sort of surprising to see this RFI didn't really talk about AI. I think that AI was mentioned maybe twice throughout the whole thing. And so that's one that's missing. And I think, that would be a good example of something that can be brought up in comments, even though CMS did not focus on it. And I think CMS would appreciate it because that's what we're seeing in terms of what companies are working on and integrating more and more into their operations. Another topic that we do not see throughout this RFI is privacy and cybersecurity. So obviously, privacy and cybersecurity is more related to compliance than to the reimbursement for care and actual operations. But it's a very big part of data sharing, the maintaining of privacy and cybersecurity, both because that's something that companies worry about and have to structure around, but also because it is a concern. And the more you increase interoperability, the more you need to account for privacy and cybersecurity that goes with it. And so, in the industry, there's many vendors that build around privacy and cybersecurity, and providers always have to consider that. And so when we talk about various new features, that is a topic that we can address as well and say, well, for this function, would like to confirm that that's the privacy that's needed and not beyond that. So that's another big topic that we don't see. Another topic is Medicaid. So CMS has been good with innovating with Medicare because CMS has more control over Medicare than Medicaid. That is true. But CMS also oversees Medicaid and has historically sent letters to Medicaid state agencies instructing those agencies how to implement various aspects of technology, or at the very least advising on these topics. And so, with CTEL, with telehealth companies, there are companies that do focus on the Medicaid population or have a great Medicaid population that they serve. And so it is always helpful for CMS to be able to incentivize Medicaid to provide whatever, to facilitate new technology, digital health, and interoperability for Medicaid beneficiaries as well. Another thing that was not expressly addressed, to the chagrin of this group, probably, is the telehealth. So CMS and ONC use the term digital health quite a bit. And digital health has this limited definition of tools that help digitally. I forget the exact definition, but it does not read like a definition that would encompass telehealth. And so, unfortunately, there's almost no discussion of telehealth at all. That is a shame because telehealth has a very important role in the health tech ecosystem, in promoting the use of digital health tools in care coordination, in value-based care, all of the topics that are covered in this RFI. Telehealth, especially in the post-COVID environment, has a central role in. And so that is another topic that I think is very much worthwhile to bring to CMS's attention, despite the fact that CMS did not focus on it in the RFI itself. And then one other topic that's missing is lessons from CMMI's pilots and projects, lessons from other health IT initiatives that were done previously by CMS, like meaningful use. There's just no discussion of some of the relatively successful health IT projects that CMS has done historically. And CMS could have said, with meaningful use, we have encouraged the use of these particular EHRs, and now the vast majority of providers use EHRs that have the right standards that they support to promote interoperability. How can we use the same thing to promote interoperability for Medicare Advantage populations, or something similar? But there's no discussion of any sort of previous projects. It's more, it's a blank slate. We're starting from scratch here, and that's a shame because I think there is a lot to build on with respect to CMS. And same, there's no discussion of any other initiatives or that other entities are doing. I mentioned the VA. Obviously, it's an ecosystem that's a little bit more synchronized, but also payers. Kaiser Permanente and other payers have implemented a variety of tools that industry stakeholders took note of as helpful in patient referrals and coordination of data transfers, things like that. So all of these are missing. But as I mentioned before, just because they're missing doesn't mean that we cannot comment on them, because the purpose of this RFI is broad enough to pull these topics in. Okay. And so moving on, so the next section, I'm actually going to identify and enumerate all of the questions or topics that were raised in this RFI, and then suggest a few considerations as we look at these topics in terms of what else we can comment on, or how we can comment directly on these questions, or what other topics we can bring up that are related to the questions that are being asked. As you may know, the RFI is split among stakeholders. And so there's 5 sections, and each section pertains to a different type of stakeholder. And so you have patients and caregivers, you have providers, you have payers, you have technology vendors, and you have value-based care organizations. And so we'll proceed in the same order in which the RFI proceeds. So the first section is patients and caregivers, and the topics that this section covers are health management and care navigation tools, access to families' health information in one location, apps that would be useful for Medicare beneficiaries, apps features that are missing, CMS's role in encouraging interest in digital health products, digital health features to make apps easy and accessible, and then collecting real-world evidence of the use of digital health apps. And so I know that CTEL is working on the comments as well that addresses some of these topics, and some other topics we'll discuss later. And so my comments are going to be sort of overlapping in some parts, and in some parts they're just different. These are, on their face, are relatively straightforward with respect to what can be provided. And if you have a company that provides digital health apps or involves digital health apps as part of the care, then you can comment directly on these questions. And I think these are good questions to ask. Obviously, this all comes with the backdrop of the Blue Button 2.0, which allows app developers access to Medicare data for Medicare beneficiaries. And there's almost 100 apps, I think, now that use Blue Button 2.0. So I think that when CMS asks these questions, the intent is to see, well, is there anything else that we can do to incentivize the use of apps? I think it would be helpful in responses to, first of all, acknowledge that there's already tools that are available to beneficiaries, like Blue Button 2.0 I just mentioned. There's also the mymedicare.gov portal that has a ton of information. It's for the beneficiary. It's a portal for the beneficiary that really tries to pull all the information that exists into one place. One thing that's not mentioned but will become relevant is hardware, and specifically things like smart watches, things like smart rings. For Medicare beneficiaries, while they have phones, typically they're not as sophisticated in using apps. But with hardware, you don't need to know how to use apps. And if you have a smart ring that measures your heart rate, and it's a part of an RPM service or something like that, all of that is helpful in making sure that whenever you connect to your portal, whether it's mymedicare.gov or the one app that grandma uses because that's the app she knows how to use, the data gets pulled in. And so, I know with the telehealth companies, several have been using hardware successfully, and it's one that is worth mentioning to CMS as well. And then another topic that CMS did not bring up here, but it's definitely worth bringing up, is the complementing services that CMS does pay for. So CMS has released new G codes for CHI codes, for PIN codes, essentially helping a beneficiary navigate the benefits that they have, the care that's available to them, and CMS currently pays for this on a claim basis. When we talk about digital health to help with the same functions, care navigation, it is important to talk about how we integrate the two, and whether some of the payment that's currently is designated for services for individual to provide it, whether that can be maybe pushed a little bit towards the technological aspect, digital health, or reimburse both. So something to consider here. Still in patients and caregivers, there's questions on data access and integration, and questions about information blocking and digital identity. I'll just go through these. So, the topics covered include health data availability and the value of data that's available from CMS, value of CMS data sources, TEFCA's role in helping patients access information, HIE's role in advancing patients' access to health information, and then what are some of the most valuable health data use cases for care navigation. And then the information blocking and digital identity, the topics are encouraging patients and caregivers to submit more complaints and that is complaints of information blocking by providers or tech vendors. And then the role of digital ID credentials, including what are the pros and cons of their use, incentivizing the use for stakeholders and for patients. Again, I think these are good questions. TEFCA is something that CMS has more control over. CMS data sources is something that CMS has direct control over, and so they can make a difference pretty quickly with respect to those aspects of the health tech ecosystem. Now with CMS, when they talk about data, they talk about data sources that CMS directly controls. I would say one thing is also worth considering is CMS has more control than CMS puts on in this RFI. So CMS contracts with all the major payers. CMS contracts with the vast majority of healthcare providers, and CMS has requirements for tech vendors. And so CMS can make certain databases available by virtue of having these requirements. So for example, any carriers, health insurance carriers that participate in Medicare Advantage, there's a variety of requirements for those carriers. Some of these requirements could have to do with data, the provision of data to CMS, and then making sure that data trickles down to other entities and stakeholders in the ecosystem. Another thing that may be worth noting, and I also pointed out on this slide on the right side, is that currently, if for those of you who participate in TEFCA exchanges and the health information exchanges, there are some limitations that affect digital health companies, and that is that participation is limited for treatment purposes, and that's consistent with HIPAA. But there is some ambiguity and some gray area with respect to what does that mean, and whether a digital health company that, for example, is not structured as a friendly PC, whether they can still participate in the HIE. And we've seen some back and forth. We've seen companies getting kicked off HIEs because they did not have a professional corporation that they were operating through. So that's another issue that we have seen surface and maybe worth raising here. Then the use of information blocking complaints. It sounds like CMS really is trying to incentivize more complaints. So we see it in litigation as well. There's ongoing litigation about whether EHR vendors are blocking information from other vendors that help providers. And so one area of comment can be, how to make it easier to weaponize information blocking complaints. And so it's not just a black hole where you submit a complaint and OIG is sort of working on it in the background, but it's a more, once there's sort of a verification of the complaint, maybe it becomes more public. And so there's more pressure for entities to comply with complaints or prevent complaints. And then the last topic that's also worth sort of noting and considering is on the digital ID credentials. Like I said, it's a theme throughout this whole RFI. And so if your service, if your company provides any sort of use of digital ID credentials, it sounds like you can find some you can find some benefits from CMS. And so if you request, for example, that companies that use digital ID credentials get any additional perks, CMS appears to be open to that because they feel, based on this RFI, that these digital ID credentials are a helpful tool in making information available more easily to individuals and patients in particular. Moving on. So the next section is for providers. And with respect to providers, the RFI covers the topics we have here. So increased use of digital health in rural areas, obstacles to development and use of apps for providers, accessibility of data, and changes needed for patients to have access. And then also data exchange topics like FHIR API support, role of TEFCA in advancing provider access to health info. So here it's provider access. In the previous section, it was patient access. And then CMS's role in improving things. So supporting providers and making data available in the ecosystem, simplifying clinical quality data responsibilities, and encouraging providers to accept digital identity credentials. For this group for CETO in particular, when we see question about the increasing the use of digital health in rural areas, telehealth is key. There is plenty of research showing that individuals who receive telehealth are more likely to use other digital health. And so very much worth pointing that out to CMS. And it's true that CMS is a bit constrained in how much they can reimburse telehealth based on the statutory limitations that exist. But I would still mention that, and I would still, point out how CMS can, even within existing limitations, promote the use of telehealth, both for directly for Medicare beneficiaries, but also for Medicare Advantage. And so, and relatedly to this, you want to make the point that increase in telehealth would also encourage the use of digital health and digital involvement in patients' own data, and the spread of information between various providers that are involved in the care of the patient. And again, as I mentioned in the previous slide, we should consider CMS's full authority and scope, which is not limited to just the items that CMS discusses directly here. But again, CMS has a say in what Medicare Advantage does. CMS has the ability to provide guidance to Medicaid state agencies as well. Two other topics that are covered for providers, again, the use of digital identity credentials. So they're asking about whether there's any challenges, what is the role of these trust communities in supporting accessibility. And when they say trust communities, they mean Clear and ID.me, those. The accessibility of data that is accessed through these digital identity tools, and then changes needed for patients to have access. And then again, they go through information blocking considerations. And one very interesting question was about whether any of the information blocking exceptions should be removed. So for those of you who may be familiar, there are several exceptions to the information blocking prohibition. And those include exceptions for preventing harm to beneficiaries. There's an exception to protect privacy. There's an exception to protect security. There's a content and manner exception where you say, well, we can provide the health information requested, but it's going to be less and it's going to be in a different format. And there's a few other exceptions as well. And so CMS and ONC are openly coming out and saying, look, we created these exceptions. We believe that they're justified on policy reasons. But if you disagree, tell us, because we want to make sure that there's less information blocking going on. And that's I think a good opportunity, especially for companies that are trying to get more information from EHR vendors. EHR systems hold the bulk of the information in this ecosystem. And so when you try to get this out, as we have seen with Epic and some others, it can be challenging. And so in many cases, the EHR vendor will be pointing to certain information blocking exceptions. If we can remove those exceptions or tailor them a little bit more, that would give providers or vendors that work with providers more flexibility, especially now when there's a lot of AI-driven tools that can do quite a bit with EHR data. And so moving on to some ideas that are based on these questions. Again, leveraging digital identity. That's a recurring theme. And I think if you're thinking of ways to improve your digital product, and digital identity credentials can be implemented in some way, seems like there are some benefits that can go along with it from CMS. And the other one I already discussed is tailoring information blocking exceptions. So if you've come into challenges with information blocking, this would be a good time to submit comments stating, why certain exceptions are overused or being abused by EHR vendors or maybe others. Moving on, the next section is for payers. And so there's these topics that are covered for payers, TEFCA limitations, CMS roles in encouraging payers to accelerate API adoption, CMS's role in encouraging payers to accept digital ID instead of logins. What would be a value of a nationwide provider directory with FHIR endpoints? payers' role in simplifying clinical quality data responsibilities of providers, and then CMS's role in encouraging payers to submit information blocking complaints. For this group, for CTEL in particular, payers are oftentimes a source of revenue, obviously, but also in many cases a source of referrals. And so one comment that can be submitted is the importance of data exchange between payers and providers, including the referral of patients. And so, within the payer ecosystem, depending on how you are positioned, how your company is positioned with payers, you may benefit from requiring payers, for example, to disclose to patients all of the in-network providers whenever they suggest a provider. So if a payer has a preferred, telehealth solution for, X condition, and you are a smaller provider, you can maybe submit a comment that says, well, the payer should be providing all the options because the patient needs to know about the options. Whereas if you're a bigger player and you have this preferred relationship with the payer, and you've sort of established good quality criteria that you've been following, and the payer is really happy with you and is more likely to recommend you based on that history together, then you can submit a comment saying that, well, payers should highlight the benefits of working with particular providers, to let patients know that these particular providers have been effective and helpful in the past. And another angle for a comment could be expanding interoperability requirements. As I mentioned earlier, payers are already required to provide certain data about participating providers as part of the interoperability rule. CMS appears to be open to have additional requirements put on payers to disclose additional information, and make it easily accessible and digestible by providers. The next section was for the stakeholder, tech vendors, data providers, and networks. And so there's discussion of the ecosystem and digital identity. A lot of that discussion was about stimulating developer interest in products, and working more with CMS data, and again, adopting digital identity credentialing tools. A few ideas for comments is notifying CMS or bringing to their attention that it would be incentivizing to have some sort of reimbursement for digital health products beyond what we have now. So right now, if you want to get reimbursed for a tech product, for a digital health product, there's limited opportunities. It could be sort of packaged into an RPM, RTM, and there's you can get into like DME and some categories, but it'll be nice to have a more explicit category that covers a broader spectrum or the products that are out there, that have been appearing quite a bit elsewhere outside of Medicare and reimbursed as well. And again, very worthwhile mentioning the role of telehealth solutions in the ecosystem. And so tech vendors, telehealth solutions have been implementing technology at a higher rate than traditional legacy providers. And so the importance of telehealth in spreading digital health products and care coordination products. There's a few other questions and topics that CMS brought up. Upon reflection, I'm probably not going to go through all of these, but you can see them on the screen. Some of the ones that are worth noting, they talk about US CDI, and the role and the limitations of US CDI in improving interoperability and exchange. US CDI, as you know, is sort of the data set, sort of standard data set that has been updated historically. I think participation in updating US CDI is helpful. So maybe something to comment on. Another thing that may be worth commenting on is the relationship between data transactions and state laws. So now there's more and more state privacy laws that govern the health data, and there's two that are specifically aimed at health data, the one in Washington and the one in New York, that are layered on top of HIPAA. And so getting clarity on the privacy and compliance side would be helpful for both providers and tech vendors. Moving on, a few more questions, in particular in the data exchange. So CMS brings up endorsement of non-CMS data sources, which, there are quite a few non-CMS data sources that are out there, historically that have been available by, you name it, IQVIA or Experian or, Flatiron. There's just been a variety of sources where you can get a variety of data. And CMS has not publicly endorsed any of those, but may be worthwhile. And so depending on your use of the data, your company's use of data, it may be helpful for CMS to say, you know, to say that a certain data source or database is an acceptable database to use to reach certain conclusions or provide certain services. There's a lot of open-ended questions about the use of FHIR APIs, pros and cons, and the use of bulk FHIR APIs. I think the idea is that with bulk FHIR APIs, you would reduce the burden on providers, and data could be transferred directly to CMS or payers. The CMS also raised this idea, the role of CMS in ensuring viability of healthcare data sharing network, including enough supply and demand that results in usage and outcomes. So I think good questions. And for those of you who are directly involved in some of these questions, it'll be great to provide to CMS what you know with an idea of how to actually use it. And if you have that, I'd certainly encourage that. And we're nearing the end here. This is the last section for tech vendors, and it talks about compliance. So again, information blocking, examples of violations. In this section, they actually, CMS explicitly is asking about CMS policies. What CMS policies would be helpful in guiding information blocking? And so that is, I think, a great question and an opportunity to submit ideas for how to implement some of the exceptions and what to identify as definitely an information blocking practice that would give cover to healthcare providers that are trying to get data. And there's also a section on price transparency implementation as well. The last stakeholder that is addressed in this RFI is the value-based care organizations. In that one, there's several topics that are covered: digital health adoption, compliance and certification, and technical standards. It's a sort of a big picture. There's more requirements on value-based care organizations than there are on other organizations because CMS is more directly involved, or CMMI is more directly involved with APMs. And so there's an opportunity to impose more novel requirements and have higher uptake with respect to technology and data. And so CMS's questions are essentially, how do we do that? And what kind of technology and data should be required of APMs? If you're in an APM environment, that's something that's certainly worthwhile commenting on. There was a few initial comments that we've seen already. Just to give you an idea of topics that have been brought up, there was one comment talking about the use of blockchain, several promotion comments talking about a business's own, like the submitter's own solutions, including platforms that integrate telehealth, RPM, CCM, and billing with screenshots, examples, links to videos. And there was another comment specifically talking about a unified health operating system that's provided by a specific vendor. And there's also quite a few comments that are just a two-sentence, we support this, or, your main CMS, your main problem is that you don't do X, Y, Z. So not helpful comments. And so the trade groups typically submit towards the end of the deadline, closer to the deadline. And so we're monitoring those as well. But so far, it's been sort of a hodgepodge without any sort of good centralized comments yet. And so I think CTEL's comment is going to be good and effective in that both it represents a bunch of providers, and also it's going to be a thoughtful one with suggestions. But that gives you an idea of the landscape as it stands. So with that, hopefully this was helpful. I'm going to check the chat again to see if anybody has any questions. But if there are any questions after the presentation, or if a template would be helpful, feel free to reach out. Happy to discuss or help with this in any way I can.
Thank you, Igor. It looks like we have a question from Trisha Kess. A quick question. Are you all reading this RFI as applicable to commercial as well as MA? It seems like it could read either way. Oh,
So,
oh, go
sure,
ahead.
yeah. So some aspects of it will affect commercial plans. But it is mostly focused on the things that CMS can directly change. And so that's why the focus is on CMS's data sources. The focus is on the CMMI programs, the programs that CMS has the most control over. The way this will affect commercial plans is if requirements are put for Medicare Advantage, because a lot of times various aspects of Medicare Advantage tend to bleed into commercial. Same with digital ID tools, credentialing tools. Once those are more widespread, they'll be used in the ecosystem more broadly. And same with data practices. And so if TEFCA or other data standards or data pools are expanded, that would have implications for commercial plans as well. And also reimbursement. Once Medicare starts reimbursing certain services, particularly innovative services, it is common for commercial plans to follow. It goes, fee for service, Medicare Advantage, and then commercial plans typically follow. And then, Krista, I don't know if you're speaking, but if you are, you're on mute.
I think we got one more question. Perfect, thanks. That's what I thought, but I wanted to confirm. Okay, wonderful. Bill England, because CMS does not get individual. Bill, are you still on? I don't want to. Might be better if you just go on.
Hi, Krista. Yes, I'm on.
Do you want to ask your question? Or
well, just a comment talking about promoting telehealth in rural areas, that it's really hard to know what's going on in the MA plans because there's no data reported. The only solution I could think of would be requiring some sort of reporting, if it's not claims, or just how it's being taken up. I mean, there's incentives provided, but who's responding? If that
I think that absolutely makes sense. And in this RFI, there's not an acknowledgement that CMS has the ability to require things or incentivize things in Medicare Advantage. And that is an acknowledgement that should have been made, and that is something that should be pointed out. Because Medicare Advantage has so much data that is valuable for providers and patients. And CMS has the ability to tie strings to that data and incentivize carriers, payers to provide the data either in aggregated form, the identified form, or in some sort of other secure way to make more data available to both providers and patients.
Thank you. Yes, exactly.
We are have about 1 minute left. Does anyone else have any questions?
So I see one in the chat that says, "Isn't telehealth like digital health?" There's not. It doesn't seem that way in this RFI. In this RFI, to me, the way I read it is when they say digital health, it does not indicate some sort of a synchronous video session. It's more apps, mobile apps, and so it is up to us to say digital health should include telehealth, and telehealth has a big role.
Thanks, Igor, because I was being a little tongue in cheek, but I guess if it's not on the telehealth medical services CPT list, it's not telehealth. So I can see that's one way to remind them, like, you've left out all the CPT codes on that list, and it would be pretty good to determine which ones you would consider doing asynchronously, even like, the ones that are like GQ or GQ modifier, like the asynchronous ones that could be considered a bit more like, the pilot programs for Hawaii and Alaska, but pilot programs for the last 20 years. But it's a very good point. And
Right.
now I'm incentivized to write a letter on my own behalf as a private citizen.
I've succeeded in this presentation.
Yes.
Yeah. No, absolutely. Yeah. And with Hawaii and Alaska, they have the statutory backing for that. Whereas for other things, they're a little bit, they don't. And so they're more conservative with those. And so it's up to us to embolden them, to give them ideas and to say, look, this is important. And this administration looks more willing to, break things, what is it? Hurry up and break things and then ask questions later. So sure, if it can be done to promote telehealth in a way that's sensible and that's in accordance with best practices, okay, yeah, adopt telehealth.
Well, thank you, Igor, for a wonderful presentation and being so generous with your time with us today. If anyone has any questions, please reach out to Igor. He is a partner at King & Spalding, and his email is listed on the PowerPoint slide. If for some reason you forget it, just reach out to me at info@ctel.org, and we'll make sure to send all of Igor's contact information over to you. Thank you, Igor. Have a great day.
Thanks for having me.
Thank you, Igor.